Good morning everyone. Today we will discuss about development of midgut. We all know that due to folding of the embryo, the yolk sac is incorporated within the embryonic disc and it lead to formation of the primitive gut. This is primitive gut, and this primitive gut remains in communication with the remaining yolk sac by vitello-intestinal duct, and this is the remaining yolk sac which is outside the embryonic disc. So, what is the extent of the midgut? This midgut is initially this primitive gut has been divided into foregut, midgut, and hindgut. Foregut is extending from cranial part of the gut up to the second part of the duodenum where the bile ducts opens. And then from here the midgut is starting from the second part of the duodenum where the bile duct is opening, you can see here, and it extends up to the junction of the right 2/3 and left 1/3 of the transverse colon. So, this is the extent of midgut from second part of the duodenum where the bile duct is opening up to the junction of right 2/3 and left 1/3 of the transverse colon. And this junction of the foregut and midgut is also known as anterior intestinal portal, and junction of midgut and hindgut is known as posterior intestinal portal. Now, this loop of the midgut elongates and form a U-shaped primary intestinal loop, and this primary intestinal loop is connected by a narrow stalk to the yolk sac, and that is called as vitello-intestinal duct. In this diagram you can see the artery of the midgut, which is superior mesenteric artery, and this midgut loop is forming a U-shaped loop in which the superior mesenteric artery is forming the axis of this loop, and this midgut loop is connected with the yolk sac by vitello-intestinal duct. So, this is vitello-intestinal duct and this is yolk sac, and midgut loop, which is U shape, is connected by vitello-intestinal duct. Now, what are the derivatives of the midgut in adults? This midgut loop initially has been divided by superior mesenteric artery into two parts. The part cranial to it is the prearterial segment and part caudal to it is the postarterial segment. Prearterial segment give rise to distal half of the duodenum, jejunum, ileum except its terminal part, and the postarterial loop, it will give rise to terminal part of the ileum and the cecum, appendix, ascending colon, and right 2/3 of the transverse colon. So, these are the derivatives of the midgut in adults. Now, what are the stages of development of midgut? This midgut loop elongates excessively during 5th to 6th week of intrauterine life, and that leads to herniation of the umbilical herniation of the midgut loop. So, first stage is the physiological hernia, physiological umbilical hernia, which occurs around 6th to 10th week of the intrauterine life. Then rotation of the midgut loop, which is around 270° anti-clockwise direction, and initial first 90° rotation occurs during herniation of the loop, and it is within the extraembryonic coelom of the umbilicus, or we can say this first 90° rotation is occurring outside the abdominal cavity, and rest of the 180° rotation is occurring during return of the intestinal loop, or we can say during retraction of the intestinal loop. Then the stage is retraction of the intestinal loop and is the fixation of the intestinal loop. So, the stages of development of the midgut are physiological umbilical hernia, then rotation of the midgut loop, then return of the intestinal loop, which occur after 10th week of intrauterine life, and then fixation of the intestine, in which the mesentery or the mesocolons are hanging the loop of intestine and the colon, and also the some part of the colon become retroperitoneal. So, that is the fixation of the intestine. Now, coming to the first stage, that is physiological umbilical herniation. This stage begins during 6th week of intrauterine life, and why this occurs, why the physiological hernia occurs? and because during 5th week of intrauterine life, the midgut loop elongates excessively, and mainly the pre-arterial loop elongates, and at the same time liver is also enlarging. This is developing liver which is also enlarging at this time, and also the at the same time the kidney is also developing. So the size of the abdominal cavity is not enough to accommodate the loops of intestine. That's why the loop of the midgut herniates through the umbilical opening, and it comes into the extra embryonic coelom. So this is the abdominal cavity, and the loop of midgut is herniated. In this diagram you can see it is herniating into the proximal part of the umbilical cord, which has extra embryonic coelom. So the herniation of the midgut loop through umbilical opening into the proximal part of the umbilical cord where the extra embryonic coelom is extending, this is called physiological umbilical hernia. So midgut loop herniates through umbilical opening into the extra embryonic coelom. This is called as physiological umbilical hernia, and the time of this hernia is during 6th week of the intrauterine life. And here in this diagram you can see this is the superior mesenteric artery, and this is the pre-arterial loop, and this is the post-arterial segment of the intestinal loop. Now in this diagram you can see the herniated communication between intraembryonic and extraembryonic coelom, because initial midgut lies in the intraembryonic coelom and now it is herniating into the extraembryonic coelom. So due to this herniation, during this time the extraembryonic coelom and intraembryonic coelom both are in communication with each other. This white part, this part is showing the intraembryonic coelom, and this here is showing the extraembryonic coelom. So due to herniation both are communicating, both cavities are communicating with each other. Now this second stage, that is the rotation of midgut loop. What the purpose of rotation? The purpose of rotation is to there is return of herniated loops into the abdominal cavity. So this is helping in returning the loops of intestine into the abdominal cavity, and also establishing the definitive position of the various part of the intestine. The axis of rotation is formed by the superior mesenteric artery, and direction of rotation is 270 degree anti-clockwise. Initial 90-degree rotation is occurring during herniation. So it is occurring at the 6th week of intrauterine life, and it is occurring outside the abdominal cavity or within the umbilicus. In this condition, because of 90-degree rotation, first 90-degree rotation, this pre-arterial segment shift towards the left side, and post-arterial segment comes to the right. The pre-arterial segment come on the right side and post-arterial on the left side. Now you can see the first 90-degree rotation of the midgut. This is the midgut loop pre-arterial segment, and it elongates excessively. It forms the loops of the jejunum, mainly jejunum and ileum. And here you can see because you can see the 90-degree rotation is occurring, and because of this 90-degree rotation, this pre-arterial segment, which was the loops of intestine initially was in sagittal plane. Now after 90-degree rotation in an anti-clockwise direction, the pre-arterial segment comes on the right side, and this post-arterial segment comes on the left side, and we are looking from the front side. Okay, we are looking from the front or the ventral side of the body. So because of this rotation, pre-arterial segment is coming on the right side and post on the left side. Now after 10th week, in the abdominal cavity has been enlarged, and growth of liver is not so much as compared to before. and the kidney also has been in mesonephric kidney also are regressing. That's why the abdominal cavity is enough to accommodate the midgut loop. So this is the time to retraction. So the rest of the 180-degree rotation occurs during the time of retraction of midgut loop or during return of midgut loop into the abdominal cavity. So initially the prearterial segment returned to the abdominal cavity. Here you can see the prearterial segment, which is the coiled one. It is entering into the abdominal cavity first, and during this time again 90-degree rotation in anti-clockwise direction is occurring. And what happens due to this rotation? This prearterial segment is going behind the superior mesenteric artery. You can see in this diagram, because of return of the jejunal or prearterial loop, this is going behind the superior mesenteric artery. This is superior mesenteric artery, and because of this rotation, this return, this prearterial loop will go first into the abdominal cavity, and it will occupy the central part of the abdominal cavity and slightly towards the left side. So, and it is going, this loop is going behind the superior mesenteric artery. This is the reason why the superior mesenteric artery goes in comes in front of the duodenum, or we can say the duodenum goes behind the superior mesenteric artery. So the two rotation of 90-degree has been occurred. Now lastly the post arterial segment will return into the abdominal cavity. You can see in the diagram, now this is the post arterial segment which is returning into the abdominal cavity, and it will come in front of the superior mesenteric artery. And at the same time the 90-degree third 90-degree anti-clockwise rotation is occurring. So in this diagram third 90-degree rotation is occurring, and this post arterial segment has come into the abdominal cavity. Now initially this cecum is in subhepatic position. This is developing liver, and initially the cecum is in subhepatic position. So cecum and appendix is in subhepatic position. Now due to growth of the posterior abdominal wall, the cecum will descend and come into final position, that is in the right iliac fossa. Now cecum has come into the right iliac fossa, and due to this descending colon and transverse colon assumes its final position. So the second and third rotation of 90-degree anti-clockwise direction, these are occurring during return of intestinal loop, or the returning of prearterial segment. The second 90-degree rotation is occurring, and when the post arterial segment is returning, the third rotation is occurring. Now so we can say this loop, retraction of the intestinal loop, is at the end of the 10th week, and the prearterial segment will re-enter first, and the post arterial segment or the cecum will re-enter at last. Why this post arterial segment will return at the last? Because of cecal bud is developing in the post arterial segment, and it will interfere in return of the post arterial segment. That's why the post arterial segment will enter into the last, and cecum is the last organ to enter into the abdominal cavity, and jejunum is the first organ which will re-enter into the abdominal cavity. And the reasons of retraction, as we have discussed, that because of enlargement of the abdominal cavity and relative decrease in size of the liver and kidney are the important factors for retraction, and timings of retraction is at the end of 10th week. Now the fixation of intestine. In this the duodenum, colon, sigmoid colon, duodenum and most of the colon except the first half of the first part of the duodenum, transverse colon and sigmoid colon, they all are pressed against the posterior abdominal wall, and their mesentery is absorbed, and these organ gets retroperitoneal. So the first part of the duodenum, transverse colon and sigmoid colon are not retroperitoneal because they doesn't lost their mesentery, they retain their mesentery. And in this process, the process of fixation of the gut, the mesentery of small intestine also comes into its final position. In this diagram you can see the mesentery of ascending and descending colon, and most of the duodenum has been lost, but the transverse colon, sigmoid colon and appendix, they retain their mesentery, and the mesentery of small intestine comes into the final position, that is from the duodenojejunal flexure up to the right sacroiliac joint. This is the final position of the attachment of the root of mesentery. Here you can see in the first diagram, it is the initial position of the mesentery attachment, and this is the final position has been achieved. Okay. So this is the fixation of intestine or fixation of gut. Now come to the applied anatomy. First is the omphalocele or the exomphalos. It is the condition where the physiological hernia is occurring, but herniated loop fails to return into the abdominal cavity. When it is the herniated loop are not returning into the abdominal cavity during 10th week of intrauterine life, a transparent membrane or covering is present in around the coils of loop of intestine, and this is seen outside the umbilicus, and this condition is called as omphalocele or exomphalos. And this condition is usually associated with trisomy 13 or 19, and also with the severe malformation like cardiac and neural tube defects. So the mortality is high in omphalocele or exomphalos. Alpha fetoprotein in this condition will remain high. So this is omphalocele, and you can see the transparent covering around it, that is amnion. So the reason of exomphalos is due to non-return of the or failure of return of the herniated coils of midgut into the abdominal cavity. Now anomalies due to error of rotation of the gut. Sometimes due to non-rotation of the gut, the location of colon will be on the left side and small intestine will be on the right side of the abdomen. You can see in the first diagram. And sometimes there will be reverse rotation. In the second diagram you can see, due to reverse rotation, the transverse colon will be behind the duodenum, and coils of intestine or duodenum will be in front of the transverse colon. Now I have told you the omphalocele, and this omphalocele condition can be confused with an anomaly that is called as gastroschisis. It is not due to rotation or herniation anomaly. It is the anomaly due to defect in abnormal closure of the abdominal wall. What happens in this condition? The loops of the intestine we can see outside the umbilicus, and it is usually on the right side, and the defect occurs due to abnormal closure of the body wall around the connecting stalk. And how we can differentiate? In this condition, the herniated loops are not covered with any amnion, so they are exposed to the amniotic fluid, and the prognosis of this condition is good because it is not associated with any cardiac or neural tube defects or any other genetic defects. Now coming to the Meckel's diverticulum. What is Meckel's diverticulum? A small diverticulum which is arising from the anti-mesenteric border of the ileum, that is the Meckel's diverticulum, and it is a true diverticulum which is arising from the, or we can say it is the proximal part of the vitellointestinal duct which is remaining. Here you can see this is the midgut loop, and this is the vitellointestinal duct which is connecting it with the yolk sac. So most of the part of this vitellointestinal duct usually obliterate around 10th week, but sometimes its proximal part will be remaining. Here in this diagram you can see the dotted line is representing the obliterated part, and proximal part is persisting. If the proximal part of the vitellointestinal duct is persisting, then it is forming the, or it is called as Meckel's diverticulum. So this diverticulum is arising from the anti-mesenteric border. This is mesenteric border and this is anti-mesenteric border. So Meckel's diverticulum is attached on the anti-mesenteric border, and it is a true diverticulum because it is containing all the layers of the GIT as the ileum contains. And for this the rule of 2 is applied, that it is 2 inches long and it is present 2 feet proximal to the ileocecal junction. This is ileocecal junction, and it is this Meckel's diverticulum is 2 feet proximal to the ileocecal junction, and it is present in 2% people. And here the two types of mucosa may be there, that is, one is the gastric mucosa and second one is the pancreatic tissue. So there may be ulceration, bleeding or perforation may be in the Meckel's diverticulum, and this condition may mimic with the appendicitis. So what is Meckel's diverticulum? It is a persisting proximal part of the vitellointestinal duct, and it is a true diverticulum which contains all the layers of the GIT, and rule of 2 has been applied for this. It is 2 inches long, it is 2 feet proximal to the ileocecal junction, present in 2% people, and it may contain 2 types of mucosa, that one is the gastric mucosa or second one is the pancreatic tissue. And here you can see the applied about the vitellointestinal duct, or also called as omphalomesenteric duct. So this vitellointestinal duct completely obliterates around 10th week of intrauterine life normally, but in 2% of cases it may form the Meckel's diverticulum. But if the proximal part is persisting, but if the distal part is persisting, it may form the sinus. If the vitellointestinal duct completely persisting, it will form the vitellointestinal fistula, and from this fistula the midgut contents may come out through the umbilical opening. So fecal material or the midgut contents may come out through the umbilicus. That's why it is called as fecal fistula. And the third condition, in which the proximal and distal both part has been obliterated but the middle part is persisting, that is called as umbilical cyst. So if the proximal part of the vitellointestinal duct is persisting, then it is called as Meckel's diverticulum. If the distal part is persisting, then it forms the umbilical sinus. If the middle part is persisting, it will form the umbilical cyst. And if the whole vitellointestinal duct is persisting, then it will form the vitelline fistula, vitellointestinal fistula, or also called as fecal fistula. And sometimes the raspberry tumor is present at umbilicus, which is representing the distal persistent part of the vitellointestinal duct. This is raspberry tumor at umbilicus. Now coming to the development of midgut. Here you can see the superior mesenteric artery and prearterial and the postarterial loop. From the postarterial segment, a cecal bud is arising, and this cecal bud will form the cecum, and from the apex of the cecum, appendix is arising and it is growing in length. Now what happens? This appendix is growing into length, and after birth, this cecum, this cecum is like this, but after birth the right and left, this forms the right and left cecal saccule, they will grow, and the right cecal pouch grow excessively, and then that will lead to final position of the cecum, which comes on the medial side. So because of excessive growth of the cecal pouch of the right side, it will lead to shifting of the appendix on the medial side. So initially the cecal bud is arising from the postarterial segment, and from its apex a diverticulum is arising, that is called as appendix. This appendix is growing into length, and after birth right and left cecal pouches are formed, which are growing but the right cecal pouch grow excessively, which that will shift the appendix on the posteromedial position. So, appendix finally comes on the posteromedial aspect of the cecum, and it becomes retrocecal in position. Now, what initially the cecum comes in subhepatic position. We have discussed in midgut, but after growth of posterior abdominal wall or due to descent, the cecum will come into the right iliac fossa region, but sometimes it doesn't descend and it remains in lumbar position. Here you can see in this diagram, this remain in lumbar position, and sometimes because of excessive descent it comes into the pelvic position. So, that is called as pelvic cecum. Now, subhepatic cecum or appendix. In this diagram, you can see the subhepatic cecum and appendix. It is due to a small ascending colon. If the ascending colon doesn't form, or if it is very small or short, the cecum does not descend and it remains in subhepatic position. This is called as subhepatic cecum and appendix. If there is inflammation in appendix, the appendicitis will mimic the feature of cholecystitis, because gallbladder is also in this position and appendix is also in this position. So, because of subhepatic condition, the pain will be in the right hypochondrial region. So, we will confuse it with the, so diagnosis will be mistaken, and mistaken diagnosis of the cholecystitis will be there. So, that's all about cecum, appendix and development of midgut. Thank you.